This is Senate Finance. Oh,
No, we're in that.
I'm good now, okay. This is Senate Finance. This is March 26th. And I have not seen our witnesses. They're on the screen, okay. We have not received any bills from the House. I understand there are several, mostly tax related, coming our way. But no recommendations yet on the biggest problem we've got, which is the massive increase in property taxes, which really is, it's coming close to making Vermont unaffordable for most people. Well, so, we tried to solve this problem a few years ago, and we did forced mergers, required mergers, and I thought we'd ask, how did we do with that? How many schools have we actually closed? Because I know I've got schools in my area that have merged in the form of they have one school board, but they still have 4 or 5 schools. They still have a principal in every school. They still have a kindergarten in every school. And I'm starting to think maybe our system of very small local schools has hit the financial wall this year. I don't think the schools are on a spending spree, and we're trying to find a way out. So I know, Heather, are you starting, or is Emily starting? I'm just throwing it out. The floor is yours.
Thank you, Madam Chair. It's nice to see you. It looks like you're behind some beautiful daffodils, so
Yes.
I can't really see you. Yes, hello, for the
I like
record,
it,
good
Heather.
afternoon. My name is Heather Boucher. I'm the Interim Secretary of Education. It's nice to see you all. I am joined by Emily Simmons, who is AOE's General Counsel.
Hey, everybody.
I will start just by saying, to my knowledge, we have not had legislation, certainly in the past 8.5 years that I've been here, that has required school consolidation. So I would like to say that off the bat. If you were perhaps referring to Act 46, which I suspect you were, that was really about governance consolidation. And so I want to be really clear. I think there had potentially been a hope that the governance consolidation would lead to school consolidation, but it was in fact not a requirement of that law. So
that was very painful to get, just that. For those of us who were there, it was painful.
It was. I personally had the luxury of also at that time being the acting Secretary of Education and getting to sign the official recommendation to the state board from the Agency of Education. It was indeed a very, very tough time. I would not disagree with that. So I thought I would actually have Ms. Simmons come and give everyone a little update about that activity, where we've been, and then we're both here for questions. If that will work with you, Madam Chair, and the rest of the committee.
I'm not seeing objection, that would work.
Perfect.
So Secretary Boucher is exactly right. The consolidation activity that has been going on for really the past 12 years has been at a statewide level about school district consolidation and not about any requirements for the operation of one school building versus another. The hope, or one of the intents of the General Assembly in passing those series of laws that all had some form of incentive for a trade of district consolidation until we got to the final phase of Act 46, when there was for the first time mandatory consolidation for some districts. One of the hopes there was that a school district that was responsible for multiple school buildings, especially where there are multiple school buildings for the same set of grades, would result in opportunities to offer one school for the same set of grades rather than multiple. We have seen some activity. We don't have a formal set of legislation or a program where we collect that information, but in those, especially in those districts where we saw early on the voluntary school district consolidation, we have seen consideration and some action on reducing the number of school buildings that one district operates for its resident and students. On the other side of the coin, there are still, remember, in Vermont, some school districts that are single school districts, a board that's responsible for the operation of one school for each set of grades. Also there, we have seen the decision locally to stop operating a school for that district. So it's happened in our larger unified union school districts as well as in our single town school districts.
We've also had some schools get out of a merger. Do we have any count on how many that's been?
That has been one, to my knowledge, where you have seen a unified union school district have a former member elect to go through the voter process to go to establish a single town school district again in Lincoln.
Okay, Stowe also has, I don't know, they told me they're not completely separate, but they have their own school board budget. But
Right.
they're, I guess, technically connected to the union district, but they're running their own school with their own school board and their own budget. So that's another kind of separation. So can we say that we haven't had a huge success in merging schools at, I know what, I've been given some numbers about what is the ideal size for a grammar school and then a higher ed school. Do you have those numbers? I remember it was $800 for a high school, or 800 students for a high school. And I thought it was somewhere around 3 for an elementary.
Well, what I have for you is, and you'll recall the in the Act 46 set of incentives for voluntary merger, that was a piece of legislation that did have a number that was characterized as ideal for a union school district, and that was 900 students. That's a number that
Your voice is fading. So what was the number?
one of the incentives, Act 46, was around the accelerated merger process. Those
Yeah.
incentives were available for a district that would serve 900 students.
Okay, would that be all the elementary schools or just the central high school?
That would be for however many schools that district operated, a total number of students in the district across all grades.
How well have we met that goal?
Many of the mergers that came out of that process did meet that criteria. I was going to reference a report we gave you in 2019 to get that number.
Would it be possible, I hope you have it, to have a list of schools, probably union districts, but then how many elementary schools there were and how many kids in each school? Would it be possible to get that?
Yeah.
That would be very helpful, I think. Okay, committee. Any questions? Okay.
I mean,
Yeah.
I don't wanna misspeak if I'm put on the spot about Act 127, et cetera. Does Stowe financially cooperate with those other towns?
I am not
Okay,
clear. They
okay,
have their own budget and their own school board.
yeah,
They are not included in the Memorial South, maybe, or some
right,
district, but I don't know the details.
okay.
but technically, they share resources, they don't.
Okay, so like kind of what we've done in a bigger sense of sharing supplies and part-time teachers.
Maybe,
Okay.
yeah, but we can get more detail. Okay. So thank you, I think that's helpful. Anything else you think it might be helpful for us to know, please send it over. But we're just starting as a committee to start looking at the affordability issue when it comes to schools. I think the potential, average 18% property tax increase, and in some towns it was much higher than that. It's got our attention. Okay. Heather, you're muted.
After all this time, I still make that
I
mistake.
know, I used to think I was gonna get a shirt that said, Senator, you muted.
It's pretty amazing. I was just going to offer that we have done some testimony in the House on not so much school size, but optimal classroom size,
Okay,
teacher-student ratio, and that might be of use to you. They're all obviously related, but not entirely the same. So the punchline there is that the punchline there is that we're pretty unique. Most of the literature that's on classroom size is trying to actually reduce classroom size from classes that were too big.
I remember when that was an issue.
Yeah, well, I don't know if it was ever an issue in Vermont. It may have been, but it certainly was an issue, has been periodically an issue in many other states, and in particular in some urban areas. But so the punchline for us is that even if we were to adopt the lowest minimum of these kind of optimal studies, we're still number one, well under that right now. And even if we adopted that minimum that they talk about, we would still be improving things for Vermont, and we would still be, according to this literature, some of which is pretty outdated now, it's important to note, but we would still be well within the small classroom size. So we don't even qualify in Vermont as small classrooms. We've coined internally in our state that we have micro classrooms. We don't even qualify. We're an outlier even in the small classroom literature, is what I want to say. Does that make sense?
For every one of those micro classrooms, we have a teacher. So, okay.
Yeah.
Okay, I think that information would also be helpful.
We can send that over, sure.
Okay, I think my goal is to have the committee understand there's a long history, but we are where we are. And I'd like to have the committee just get up to date as to where we are. Okay. Thank you. Committee, questions, comments? Okay, thank you. Sure, we'll talk to you some more before we're through this.
Great. Thank you very much.
Okay, committee. We do have one House bill, which I might just hold on to, so I have a House bill. We've taken some testimony on this. This is H 861, and it's when COVID arrived, in order to get people any kind of health care, we authorized, and I was on health and welfare when we did it, we authorized payment for telemedicine and for telephone medicine. Telephone included mental health, and that's the one place that it's valuable. Then it got going, we sent over to the Department of Financial Regulation and said, you figure it out. The question was, do you pay the same, or do the insurance companies pay the same for telephone consultation as they do for in-person? Right now, in-person telephone are paid, in-person and telemedicine, when you see that patient, are paid at the same rate. telephone has been paid at 75% of that, and that we sent over to DFR to figure out, but COVID's over and they would like a final resolution. The rate has not been set in law. So we have Sebastian Rodrigo. Sebastian, we've had the joy of doing all of this.
Thank you. Sebastian Arduengo for the Department of Financial Regulation. And yes, audio only services has been quite a journey for the department and I think for all of the stakeholders involved. My recollection is that when the department adopted the audio only services payment order back in 2022, at one point there were approximately 80 stakeholders in our working group to discuss all of the various issues with audio only services because as you noted, it was not covered at all by commercial insurers prior to the COVID-19 pandemic. So today I'd like to discuss some of the work we did, why we did things the way we did for the last 3 years, and some of the findings that we took away from both our work and the study that we conducted with the Vermont Program for Quality in Healthcare, which I believe you've already heard testimony on.
I don't know that we have,
We did.
we have,
The Vermont,
Yes, last week.
okay.
Yes,
Oh, I
VPQHC.
thought I knew all the players, okay.
So without further ado, I'm going to share my screen and give the same presentation that I gave in the house. So okay, great. Now if I can make that a little bit bigger, awesome. There we go. Okay. So in 2021, the legislature enacted Act 6, which required health insurers to provide coverage for audio-only services with otherwise permissible deductibles and co-pays. And also said that health insurers couldn't require insurers to require providers to have a pre-existing relationship with a patient to perform audio-only services and get reimbursed.
And this was during COVID.
Yes. As part of that legislation, 18 VSA 9362 was important. And this has to do with requirements for providers and not insurers. But the reason I want to share it with you is that it gives a little bit of background into the sorts of things that the department was thinking about when we adopted our audio only payment order. So section 9362 requires providers to comply with any training requirements for audio only, but also, and I think this is the important part, the providers have to document in the EHR, which is the electronic health record, the patient's informed consent for receiving audio only services, and the reason that the provider determined that it was clinically appropriate to deliver care by that modality. So in theory, if we were to look at a patient's EHR who was receiving audio only care, we would see those two things. And I think it's really important to note that audio only healthcare in Vermont can only be performed with the patient's consent. And the legislature also provided that there were a couple of things that we can't use audio only care for, which is basically determinations on whether someone is in need of psychiatric treatment or in need of inpatient hospitalization or inpatient psychiatric hospitalization. So as part of Act 6, the department worked with stakeholders, and as I mentioned earlier, there were at one point about 80 stakeholders in the working group to adopt an audio-only telephone order. And that went into place on January 1st, 2022. And what we said was that health insurers must provide reimbursement for audio-only services billed using accepted CPT language and definitions, which is to say that if there were codes for audio-only, providers were to use those codes, but otherwise, they could build codes with a V3 or V4 modifier to tell us and to tell the insurers the service was being performed audio only. We also allowed providers to do differential reimbursement, meaning that based on the insurer's judgment on how the clinical value of those services, we allowed them to reimburse at a rate of no less than 75% of the rate for an in-person service. So an insurer could reimburse at parity with in-person, but if they did not, they were limited to reimbursing at no less than 75%. So if you've heard testimony about a 75% floor for audio only, that is what that testimony refers to. So let me just go back one slide to give the committee a little bit of background on what the insurers did with that order. Both Blue Cross Blue Shield and MVP Healthcare wound up adopting audio-only policies that reimbursed mental health services at parity with in-person services, but reimbursed other medical services at 75% of the in-person rate. So the reason that we're here today is to discuss the results of the last 3 years of having reimbursement for audio-only services under the department's order. And we worked with the Vermont Program for Quality in Healthcare and the Green Mountain Care Board, because we utilized the VCure's claims database to try and figure out how audio-only services were being utilized and to the extent we could, the quality of that care. And then we tried to also see what impact coverage it had. And the original intent of Act 6 was to for us to come back with a recommendation on how best to incorporate these services into a value-based payment framework. So over October and November of last year, the department, the board, and VPQHC held stakeholder meetings with both payers and providers to discuss how audio-only payments have been going for the last 3 years and to see if payers or providers had any recommendations for how we should measure utilization. And based on those conversations, what we wound up doing is looking at broad categories of claims and VCuRs. And because we use Vickers, there are a lot of caveats to the data. Most notably, there are a number of payers that the database does not include. They are up on the board. And the database doesn't have any clinical information. So we can see that an audio only claim was made, but we don't know the circumstances of that claim or whether the patient had no other option to come in person. What the clinical circumstances were. So just keep that in mind as we go through the data again. The analytic approach we used, which again was very broad, looked at the procedure code modifier, which like I testified to before is the V3 or V4 at the end of the claim, or the place of service code, which is basically a code that is submitted by the provider to indicate where the service was performed, and there are codes for telemedicine. So there are a number of high-level findings we made, and I think the biggest one from our perspective is that utilization returned to a level that was comparable to the pre-COVID period in 2021. And at that point, telehealth, which includes audiovisual and audio only, represented about 11% of all services. And I want to show you now a chart from the VPQHC presentation that you saw last week to give you an idea of where the utilization ended up falling. So this is a chart of professional services by modality and year. And here's the dip in utilization that was caused by COVID. You can see that it recovers by 2021. But this whole period, audio only services is this little blue sliver of claims. It is never more than 1% of overall claims, and the overwhelming majority of claims are still in person, with about 10% being audio-visual telehealth. And yeah,
where do these years begin and where it says 219, is that January?
yeah. So the years begin on January 1st. We are fortunate in the healthcare world that the plan year overlaps with the calendar year.
So as 2020 begins, we're sort of at a low.
Yeah.
And it climbs over 2020.
Yeah.
Okay.
And the big takeaway from this analysis that I believe that the committee needs to walk away with is that telehealth, which is audio only and audiovisual, has been used as a substitute for in-person services, not as a addition to in-person services.
Yeah. Question regarding the effect of COVID. COVID would appear on the map, what, late in 2019?
Very late.
Very late.
Yeah.
And Rich.
And the thing that I'm concerned or really questioned about is that the decline in all modes of service began, who knows when, but at the beginning of this chart, at the beginning of 2018, declined entirely through 2018 and continued to decline precipitously in 2019 before COVID even surfaced.
Yeah, I think I can explain how the chart, like, this is just a straight line chart. It's not month by month. So,
So in other words, you took the beginning of 18 and the beginning of 19 and just drew
Exactly.
a line between them.
Yes.
So if you
That-
take 19 to 20, that's still a precipitous drive because you didn't
Yeah.
really begin to see COVID until
Right, but this, for
December.
2020, it's the whole year. This isn't a histographic chart that is month by month.
Oh, yeah, but you're beginning of 19 to the beginning of 20. Right?
Yeah, so what this is showing is that claims in 2020 were a lot lower than in 2019, which is because of the closures and inability to access providers during the first few months of the COVID-19 pandemic.
The COVID-19 pandemic,
It didn't begin until early spring of 2020, but again, this is just a simple line chart where the point on the line is meant to represent the whole year, it's
but
not.
that's the point. If it didn't begin until very late in the year, you've gone from roughly 9 million claims at the beginning of the year down to, looks like someplace like 6.8 million claims the in the following year.
Yeah, there was a precipitous drop.
And I'm just trying to understand the precipitous drop, at least in terms of where it's occurring, doesn't seem to have anything to do with COVID. So I'm trying to understand, why was there a drop like that?
Because the overall utilization in 2020 was lower than in 2019. This is not this is not intended to show that, like, between say October of 2019 and April of 2020 that there was a continuous decline in claims. This is trying to show that overall claims in calendar year or plan year 2020 was about 1 million claim lines lower than it was in calendar year or plan year 2019.
I'm just trying to, again, understand the validity of the data. Because the data in my mind would show a trend as to what's happening as events
Yeah.
occur, such as COVID. And this doesn't
Yeah,
show me
and
that.
maybe I can show you another chart from the VPQHC presentation that will hopefully clarify things and then try and move on from there. So what,
Can I ask a question about the last chart?
yeah,
I guess it doesn't seem like a revelation to me that they were used as a substitute for in-person services. I thought that was the point in many ways, that
yes. So this was a question that we were trying to answer because one of the
Oh.
issues that was raised in our working group was whether telehealth services would substitute in-person claims or add to in-person claims.
okay.
So one of the claims being made was that providers would see a patient by audio only, or would be unable to make a diagnosis or treat that patient. And then the patient would need to come in person anyway, which would add to overall claims volume, if that makes sense. So this is, I understand that this conclusion seems like it would be self-evident, but this is actually one of the questions that the department and BPQHC were trying to answer in the study.
So the question, if I call up and say I've got X, Y, and Z symptoms, and they tell me, well, you need to come in because we can't do that here. You're paying for the phone call but you would, you would, if you're paying for the phone call, you also would be paying for the office visit.
Yes, exactly, that, and that was, one of the real concerns that the insurers raised.
Double pay.
Yes. So now I'm going to flip back to the department's presentation. And this chart is the raw numbers
Can you make
that,
that a little bigger?
yes. So this chart is the raw numbers. I'll see if I can make it just a little bit bigger. There we go. That's too big. Just right. So this is the raw numbers for each of those years, broken down by payer and by service type. And again, this is just to show that audio only at its peak, which was at 2020, was never more than about 1.5% of overall claims lines. And in 2022, it's been at less than 1% for every payer. One of the things that we tried to look at in the national data was for indications of the quality of audio only services. And we thought that VPQHC had nicely articulated that standard in their 2020 report, looking at what a quality standard for audio only should be, which is basically the same standard of care that in-person patient encounters have.
So can I just make
Yeah.
sure I understand, like, there are standards for when it's even appropriate to use audio only telemedicine,
Yes.
let alone that you get the same quality of interaction.
Yes, so the idea behind the statute and the idea that's articulated here is
Yeah.
that if the provider doesn't makes the professional judgment that it is clinically inappropriate to treat a patient by audio only, they should not treat the patient or see the patient by that modality and instead just advise them to come in.
And so they don't submit a claim generally if they've heard you and then said you should just come in. It's not a claim.
Right.
Right. Okay, I don't know what we're getting at here, I guess. Like,
Yeah,
what
so
new information?
I think the bottom line is it worth the same payment as an in-person business?
Oh.
yeah, that's what we
Okay,
are
thank you.
building up to
Yeah,
that
okay, I'm
crescendo.
sorry. I hear you, but yeah,
Healthcare just gives stuff away with the money.
right.
So there are some national studies that looked at the quality of audio only services. All of the research that we did is available on the VPQHC website, which is actually a great resource, and I encourage you all to visit it. We also heard a lot from Vermont providers who in general are very positive about audio only care in terms of enabling access and that it is something that patients request. We also heard from insurers who kind of see the opposite end of the other side of that coin, if you will, in that, if a patient has an audio only, visit with their provider, and let's say it's only a 15-minute, encounter, that is something that many, members of insurance plans are not accustomed to yet. And those calls have definitely gone to insurers' customer service departments of
Right.
why am I getting billed for this phone call?
Yeah, I mean, I'm sympathetic on both sides, like, this is exactly the kind of thing I think about, like. I usually don't call the doctor for myself, now I call the doctor, the pediatrician often for my baby. You know. During the pandemic, people were saying like, call your doctor, if you have any
Yeah.
questions, call your doctor, like consult a physician. And so that's a lot of phone calls.
Yeah.
Into doctors. That they otherwise could spend all day answering,
Yes.
that don't be filled, so.
Yeah, and I think that is a good segue to the cost impact, both on the payer side and on the provider side, because providers'
Yeah.
time is worth a lot.
Yeah.
And one of the studies we looked at did find that telemedicine use, which again, in this report, we're referring to both audio only and audio visual, is associated with more time spent in the EHR. So you can imagine that you do an audio visit with your provider, but then for 5 minutes afterwards, they're still punching in information into Epic to complete the record for that encounter. But in terms of the bottom line, what we found was that because most audio only encounters are for mental health care, and mental health was reimbursed by payers at parity with in-person services throughout this entire period. And because audio only services only made up at most 1% of claims lines, that reimbursing audio only services at parity would not affect medical trend in any meaningful way.
If it was a replacement and not a substitute,
That's correct.
because do we need to be worried about like the fairness around calls into your provider about whether or not you or your child should come in?
Yeah, that's a good question, and I think that what our experience was in enacting or adopting the audio only payment order was twofold, in that as the Department of Financial Regulation, we don't have any clinicians on our staff, so we are ill-equipped to make clinical judgment calls about the value of audio only services. So that is why we gave insurers who do have clinicians on their staffs and medical directors the discretion to make those sorts of judgment calls. And as far as the equity of whether patients will be billed for short phone calls, that was definitely a concern that we had, but at least in terms of our approach to setting reimbursement for audio only services, we erred in favor of access to care.
I've been told that this would only count if it followed the same codes. And because I'd be concerned about the guy who called up and said, how long should my kids stay in quarantine
Yes,
before they can go back?
so one of the notes of progress that we've made since 2021 is that the American Medical Association, which manages the current procedural terminology, which are the codes that are billed, now have a set of codes that are to be used for audio only services in new appendix T to the CPAT. So the coding is much more standardized than it was when we looked at this issue with the stakeholders and adopted the audio only reimbursement order.
Okay. And your recommendation was?
We don't have a recommendation except to say that reimbursement at parity would likely not have any either positive or negative impact on overall medical trend.
Okay. Committee, questions?
Overall medical trend?
Yes, so medical trend, it's a term that we use to describe the cost of medical services for insurers. And trend is, you can think of it as like how much all medical services increase year over year. And because the volume of audio only services was so small, and because a lot of those services were being reimbursed at parity anyway, the impact on the overall cost increase year after year for the last 3 years would have been something like a fraction of a fraction of a fraction of a fraction of a percent.
And Brooke,
The fourth conclusion from independent providers is they do not provide audio only services due to low reimbursement.
Yeah.
Does that suggest, when you look at the other data, that if those providers, including as well as MVP and Blue Cross Blue Shield, reimburse at a greater rate, then you'd have a greater use of audio services and audiovisual services? That seems like profit motivation as much as anything else.
Yeah, so assuming that those providers start to see patients audio only, there's no reason for us to believe that those claims would be additive. So if you think about those providers that are not providing audio only services, all of their services are in person now, right?
Mm-hmm.
So if they were to switch to even seeing 3% of their patients in person or by audio only, if the reimbursement were at parity, the net impact would be 0.
Well, that's assuming that doing work in person can be done, let's say, faster or slower. What's the rate by which that can be done? The billing rate is one thing, but the rate, the number of people that you can go through on a telephone is probably easier than people walking in the waiting room and going.
Yeah, and that was a concern that we heard. But the literature kind of counterintuitively suggests that the opposite is true, in that because the provider is on the phone when they're talking to you, that it actually takes them more time overall, because then they have to enter in all of that information into the EHR.
That sounds like an IA application. But, you know, I mean, I just wonder in terms of doing these kinds of studies, and I see what this is. But the kind of study that I would envision that would actually be a test would take half your patients and treat them one way, the other half treat them another way, or half the patients in, say, Northern Vermont get
Yes.
those, and so that you actually have a population that you can compare.
I agree. It would have been fascinating to do that kind of experiment on the people of Vermont, but we
Well, on a small subset or a sample, but you know, I look at the statistics here, they don't tell me a whole lot, quite frankly, of what I'm looking at.
None of this is really to advocate or push for more audio only services. And if I recall to your concern, I believe I asked a question of somebody in the room at the last session. There is a clause elsewhere in statute, not in the bill, that says that the patient has to choose to do this.
Yes.
They can't be coerced into it, and we have other controls in
Yes.
place that no provider is going to try to finagle the system to get more triggers. We have controls in place where they can't start coming up with more reasons that hold these audio only sessions.
Well, then why do you have bullet 4 there?
we have bullet 4 there to reflect the feedback we received from the provider community and.
As I say, it doesn't
Yes.
compare with the issue of choice. That is not what that bullet says. I mean, when you look at
With the issue of
numbers,
patient choice
Yeah.
or,
well, they don't provide audiovisual only services due to low reimbursement.
You think they will start doing more of it?
That's the point.
Meaning they're being denied?
They just say. we
meaning
don't
that they
do it.
choose, they're not being denied, they are choosing not to perform those services.
And you
But
opt
what is
into
low
those services,
reimbursement?
not opt out of them.
Yeah.
Paid 75% for full volume.
That's correct.
Okay. So 75% was considered low reimbursement. Okay.
Yeah.
So. I'm still struggling with the premise that it's a substitute, only because I think there's a whole. There's a whole set of interactions that you often have that are very important, just to follow up from something, make sure you're taking the right medication. You know, get multiple opinions. I mean, I had like a medical complication after one pregnancy and I was still on medication. When I found out I was pregnant again, and I talked to a gastroenterologist on call at UVM Medical, my, OBGYN and like the pharmacist. And between the three of them, they all got on the phone to make sure I had as much information as I needed to feel like I was having I was able to substitute
Yeah.
medication without harming this pregnancy. And I felt very satisfied. There was like multiple phone calls over the course of an hour. That had to cost somebody money, right?
Right, and we don't know how that set of interactions was billed, but
I thought
when
that,
we, so when we're looking at the
Yeah.
overall
yeah,
claims, the reason that we concluded that telehealth wasn't substituting for in-person was because overall claims volume hadn't increased
okay,
from the pre-COVID baseline, which is what we would have expected to see
okay,
if what was effectively happening was patients were doubling up on claims.
right, so there'd be no reason before 2020 and after 2024. These would be treated differently unless we were just starting to value phone conversations in some kind of different way that isn't otherwise a patient visit.
Yeah, and
How are those usually billed? Like, can the insurance company tell me that?
yeah, I think the insurers would be happy to
Okay.
speak to
Yeah.
how those claims are billed.
Okay. Yeah, I don't know exactly what, but. Okay, I guess we'll have the question.
So,
Overall, healthcare costs have gone up since COVID or down or
Yes,
level or?
overall healthcare costs have gone up,
But claims have gone down.
but claims have gone down. But, what what that can tell you is that in the aggregate,
Yeah,
the cost of each claim is going up faster than claims, the number of claims are going down.
They use the same system as education funding.
Censorship.
So I'm reading the bill and I'm generally supportive of this. I'm just worried that if with this shall language, the health insurance plans shall provide the same reimbursement rate, are we inhibiting any type of creativity, innovation, where people want to provide audio only plans? And I guess I'm asking because I don't understand part B, which talks about the value-based contract for health services, and if that actually qualifies for those types of more creative offerings. Like, are we inhibiting innovative delivery of services at a lower cost by requiring this reimbursement rate?
Yeah, so again, going back to the department's process with the audio only reimbursement order, the reason that we did things the way we did in terms of applying a 75% floor was to give insurers discretion, space to innovate. The telehealth statutes, that is 8 VSA 4100 K and now L, are a bit unique in the panoply of insurance laws that we have, in that they set a reimbursement standard. So that's not to say that doing so would discourage innovation. It's only to say that it is unusual among all of the insurance regulations and mandates we have.
We don't. Okay, questions? Okay. And this is the end of your presentation? You have more.
I could talk about audio only for a long time. Yes, everyone in this room knows. So I feel that it would be best to let other people talk, and then I'll be available for
We
questions.
just got into questions. I wanted to make sure you had finished all that you wanted to present. Okay,
Thank you.
so next we have Devin Reed.
Devin Green, Vermont Association of Hospitals and Health Systems. Thank you for having me in today. And we of course are coming at this from the hospital and primary care perspective. And I really see this bill about two things. One is patient choice and the other is equal pay for equal work. So what this bill does is it reimburses at the same amount for office visits. So if it doesn't do the same thing as an office visit, then it can't get reimbursed. So if you're just calling about, I have these symptoms, should I come in or not? Or, you know, that's more triage. If you're calling about a medication or a quick question, that wouldn't necessarily be an office visit. So this only applies to office visits. I think the other piece is, it only applies to clinically appropriate office visits. So if someone needs a visual, then that person's gonna have to do regular telehealth with a visual, you know, with a screen or come in. So this is more along the lines of giving patient choice. And I think it applies to more than just mental health. I had a visit a couple of weeks ago involving my daughter and talking to a specialist, and her dad wanted to be involved in the visit, and I was running around the state house and I didn't know if I could sit down with my computer, and he had his work and all the tests had been done. We just needed to talk to a specialist, and we didn't need to drive to Burlington to talk to the specialist. There was nothing special about
doing something face to face in this arena. We just needed to hear about our options. So we were really happy to take advantage of an audio only visit where we got to talk to a specialist. And I think it makes sense for someone like a specialist or a healthcare provider to get paid the same amount if they're doing the same work. It's very similar to, there's no difference in what you're charged for calling a lawyer versus going to that lawyer's office. Same amount of money, same amount of expertise. And so that's why we're asking for parity here, is to give patients that choice. You've seen that independent providers, they found it financially not viable to offer audio only. If they were reimbursed at the same amount for the same amount of work, then they would be able to provide that as an option for their patients. So that's really why we're asking for it here today. The other piece I just also add is there's not only the audio only portion, the telephone portion, but this bill also repeals a sunset to have that reimbursement parity for audio visual telehealth. So right now, that goes away January 1st, 2026, and we would like for that to continue, and we think that's very important. A lot of people have benefited from telehealth.
Is it the same amount of service?
Yes.
Yeah, let's make this personal, right? I'm high mileage now. You get to be high mileage, the windshield wipers stop working and then brakes are soft and so on. I often call the doctor. You see, he's a friend, he's a neighbor. And it's a quick call. It's not an exam, it's not a full exam. And every now and then I make an appointment because I want him to take a look at what's bothering me. But often it's a fairly casual call.
Yeah, and if it's, so a lot depends on what you mean by casual call, but if it's just a quick sort of, I have a quick question, should I come in? That's usually not considered an office visit. And so would not be billed that way. The only things that can be billed are things that are considered office, that are similar to office visits. Again, not a triage call, not a call about medication. And also there's that protection of the thing that you, I love when my words escape me like this, the thing that you have to sign that says, I agree, consent form, yeah. The consent form, so there's also that piece too.
In 10 years of it happening.
10 years, you're giving me 10 years.
It starts young.
I mean, yeah, I think, especially given how rural and aging Vermont is, and there being, some folks either have track phones and an inability to do audio visual and would prefer telephone only. There are a lot of reasons why someone would do telephone only. Again, we've seen that it's very low percentage wise. This isn't something that's driving up the number of claims. People aren't overutilizing healthcare and double dipping. We've seen that it's remained sort of flat. That's what Sebastian was talking about.
So my favorite call, she's got another earache. Will you send out some penicillin? That would be covered.
I don't. Unless it, so again, a lot depends on the fact.
Patient, she has earaches.
Right.
So just saying, she's got one or, okay, so it would depend on whether or not they're gonna.
It's just up to the clinical
I
judgment.
would be upset if I got a bill. This would have been years ago, but
Right.
now they won't even do that over the phone. They'll say you have to come in or go to Express Care.
Yeah, so again, it's a little bit context dependent on the visit, but, and I know like what complicates it is over prescribing of antibiotics and everything else too, so.
She was on prophylactic antibiotics.
Yeah.
Will providers be banned or not allowed to incent audio only, or with the extension of the telehealth, for example, they say we could see you in person 3 months from now, but we would be able to get to you virtually on Zoom this Friday. Is that allowable? Or is that coercion into opting into what I'm anticipating or guessing is a less expensive mode of delivery for the provider?
I don't know if it's a less expensive mode of delivery for the provider. I think that was one thing that Sebastian was saying also. A lot of this is dependent on provider time. And what we found is it takes a similar amount of time for the provider to sit down with the patient, have a conversation, use their expertise and make their recommendations and their diagnoses, and then enter that information into the EHR. I think where it really saves time is on the patient's end. They don't necessarily have to drive to the office. They don't have to take off work. They can do it on a break. So I think that's where you see the saving time. I don't think you necessarily see saving time on the provider end.
Okay. They have to sign permission for audio visual?
I believe they do, yeah.
Okay.
There was one point where the consents were different.
I was just in at the beginning, we were in the middle of COVID.
Yeah.
Okay.
Just to follow up on that, that would be allowed though, but as far as you understand, that the provider could say, it could incent by being able to see them sooner rather than later.
I mean, I would say there's nothing stopping the provider but from saying that, but again, I think the amount of time it takes is the same. I don't think it makes as much of a difference for a provider, so I wouldn't necessarily see that happening.
Any questions? Thank you. And we have Mary Kate Mold. Yes.
Hello, I have not been in this room before, so introductions, my name, Mary Kate Molman. I am from Bi-State Primary Care Association. We support FQHCs in Vermont. We also support them in New Hampshire, but we must speak to Vermont.
FQHCs, this is.
Sorry.
Finance.
Yes, okay, federally qualified health centers.
We have one in place.
Yes, we have sites in every single county in the state. We serve about a third of Vermonters provide primary care. So we have a lot of a wide footprint across the state in terms of access to care. The other thing I might mention with FQHCs is there is a real focus on increasing access. That is primary to our mission as federally qualified health centers. It is what can we do to meet patients where they are, provide access, address any kind of barriers to care that is on the financial side. So we have a sliding fee scale. So that if you can't afford your copay or your deductible or you don't have insurance, you can get a reduced cost for your care. We provide transportation to make sure transportation is not a barrier. And I think that goes right into this conversation we're having around the telehealth and audio only. That is also can be a barrier to care. And I feel like I'd be saying, I'm looking at what I wrote down and what I submitted as written testimony, and it's really repeating a lot of what you heard from Jess Bernard and Devin Green. That it's about equal pay for equal amount of work, and I put those parameters around clinically appropriate work. A provider should not be seeing. She made the clinical decision that if the person really does need to be seen, if there are tests that need to be made, if there needs to be hands-on, palpitations, that person needs to be in person. But if it is a follow-up visit, if it is a part of ongoing treatment that just needs a conversation, that requires the same amount of work in terms of reviewing the chart beforehand, asking those questions, answering those questions with the patient, having discussion around that step during the visit, entering that information in the chart after the visit, doing any follow-up steps with setting up referrals. And it could be more work and more follow-up because if the person's in person and they need to talk to a nutritionist, they often can go down the hall, especially if you're in a medical home or an QHC where that nutritionist is down the hall. But then this provider may need to only do a follow-up, reach out to the nutritionist, figure out a way to bring connect the person, the patient with the nutritionist, so it's not less work. And then it goes to patient access. And I think to some of the questions you were asking, Senator Brock, so an example would be, and this happened with a friend of mine, their spouse was getting treated for cancer. That patient goes in and has a lot of treatment, a lot of visits. Not all of those visits need to be in person. If you are in the Northeast Kingdom and have very low access to high-speed internet and cannot do audio video, then audio is really your only option other than going in person. If you do not pay a provider for the equal amount of work, if you pay 75%, those providers will not offer that audio only as an option. They will still provide the care. You just need to go into the office to receive that care. So now, and I also want to be clear, if like that person had been scheduled as an in-person visit or an audio visual, and the internet went out, or it's a snowstorm, or their transportation fell through, whatever barrier, our providers would continue to provide that care for audio and at the cost of not being able to get fully reimbursed for that. I just want to be really clear. If it's a difference between not being able to provide that care and providing that care, our providers at FQHCs are going to provide that care. What they won't do, and what we are seeing with some of our providers, is offer that as scheduling. They won't say to that individual who is in the Northeast Kingdom coming in for their primary care follow-up, or their cancer consultation treatment, they'll say, no, you have to come in. And so now that patient has to drive the hour, sometimes in Vermont, that's just what we do, to get that care. And that can be, that's an hour out of their 2 hours out of their day. I'm thinking of a personal experience. I had a follow-up visit, checking on like, how is this medication going, and how did this like change in diet, how is that affecting me, and like this questioning, it's figuring out the next steps are. Do I really have time to take a full hour out of my day when I have work responsibilities like meeting with all of you? Or, running off to get my kids at their after school projects or from school or whatnot. If I can have that 15-minute call, that saves me, it makes it much easier on my life. Again, it's still the same amount of work for the provider, but for me and my choices and my preferences, that would be my choice to be able to do that. Now, if you are a person who wants to go in person, that is absolutely your prerogative, and your provider should be able to schedule you in that way. I do also want to point out that telehealth and the shift to alternative modalities of care is happening, and you're seeing, I don't know about you guys, but my inbox gets a lot of emails from Amazon Health. Or, we can consult and figure out your prescriptions. You're watching Hulu and saw an ad for a dermatology service where text your skin condition and we'll send you a prescription. I mean, these are happening, and people are gonna sign up for these because it's easy. I would rather that we make the easy choice here in Vermont for people to receive the care in the way that they can receive it conveniently, and also be connected to in-person care, comprehensive care at a patient-centered medical home, which we have invested so much here in the state of Vermont. And so making that easy option for Vermonters means also supporting the providers who provide that care. So any questions?
I was just thinking of my daughter during COVID, who said she was doing her son's orthodontia visit with her cell phone. But during COVID,
That's
got to
what we
check the
did.
braces.
That's what we did. Now, I would.
Getting it in his pouch, he says, I'm not sure.
Not sure I want to be on the fly on the wall for that or not.
No.
Maybe, yeah.
She's a vet tech, she's used to it. Unhappy clients.
Yes.
Very small phone.
Yeah, okay. So we go.
Sorry, I arrived during this part of your testimony. I'm wondering if you're aware of anyone quantifying the dollar value to patients of not having to take time off, for instance, if you were talking about not having to drive an hour out,
Mhm.
whatever it is, to an appointment and then back again. I mean, I'm thinking there can be many, many hours once you start to aggregate the hours of all patients who could use an AI visit, or whatever, audiovisual visit. And
I'm not sure I'm going so far as AI visits.
yeah, it's like back up, it's like wait,
Yeah.
online audiovisual visit.
Yeah.
And I just don't know if that's something you looked at at all, or you're aware of there are other people who have quantified that.
I couldn't point you to the study, I'd wanna look at it, I would think BPQHC and their literature search, they might have come across something like that. But I will say, in terms of quantifying, not only the time, but thinking of if you, like I'm in a position where I'm able to take paid time off from my work, there are a lot of people in hourly wage positions, they don't have that option, and when they take time off to go to their doctor's appointment, that is time that they are not getting paid.
Sure. The other thing is in the legislature, we started, especially since COVID, letting witnesses zoom in. I've heard many, many times how it allows them to participate for the 15 minutes they need to provide testimony, and then there's still at work, they step in, and then they're back to work without ever losing much less time.
There are a lot fewer people sitting in this room, can't charge rent for chairs anymore. But literally, this room would be packed rather than have half our witnesses on Zoom, and it's worked just fine.
And I imagine you get a lot more testimony from people in southern Vermont.
Right.
I do a lot less worrying about being caught on the floor and knowing I have people who have come up from Bennington
Right.
sitting here,
Yeah.
so it's easy that way.
I can speak to the savings. There was a study of cancer
I just
patients.
need you to,
Oh, sorry, Debbie Green, Vermont Association of Hospitals and Health Systems. And this is in my testimony, that's online, it's in footnote 2. But there was a study of cancer patients, and they found that the use of telehealth was associated with an average cost savings of between $147 and $186 per visit for the patient.
Thank you.
okay,
I'm gonna,
it would just be driving from St. Johnsbury to Dartmouth, I assume, because you're gonna pay the same for the office visit. Okay, but yeah, that's a long drive. And at one point, that's where you had to go for chemo, right?
Right.
If you were up anywhere in the kingdom, you had to go all the way to Dartmouth.
And Devin Green, I should clarify, this was a national study, not a Vermont study.
I guess I have a question more for Devin's testimony, and I did ask Dr. Barner.
No.
Okay.
Yes,
Yes.
that's fine.
Just to this question, I sort of got an answer, but I think it might be beneficial to, I got a good answer. I just want to clarify and think everybody would benefit from it. How much consistency is there across providers and what is defined and qualified as an office visit that could then be allowed for the telehealth? Because you, in your comments, you said it has to be an office visit. So it's not defined in Vermont statute, but it is by the AMA. So how much consistency and variability and flexibility is there for a provider to redefine or change that definition to qualify less as an office visit?
Yeah, so Devin Green, Buzz, I would say there's not a whole lot of flexibility because it's based on coding, and coding often requires you to provide what, you have to talk about what services you're providing. So there are a lot of codes for each service. And so unless you're committing fraud and not doing what you're supposed to be doing, which we haven't found here, then you'll be coding it as an office visit and you'll be providing those services.
So when we looked at the chart from Sebastian, it had Blue Cross Blue Shield having a much smaller percent of its claims being from telehealth than the other providers. I don't know if that's just because they had more claims, but it was like 0.1
Sarah's.
versus 1.6. I didn't know if Sarah was gonna get in the chair again, so that, I did notice that, it was very different than the other insurance providers.
Sure, I'm happy to come up and testify after, but Okay, and I need to look at the data again. I'm not sure if it's because we pay 75% for everything except for mental health and substance use disorder. But MVP did as well, and I don't think they saw that difference. My guess is it's.
Again,
Do I have that right? It
Yeah.
looked really different.
Sebastian Rego for the department. I will put the chart back on the screen for.
And I would just add on the Medicaid, just in the conversations with Medicaid, which I've heard from providers that they are very appreciative of Medicaid's audio only approach. And if it is correct billing, which requires a face-to-face, then that is audio visual, because that is deemed face-to-face and in person qualified for that. But if it doesn't require face-to-face, then an audio only is absolutely allowed at parity. And they pay that at parity. So just thinking through some of the standards you may be thinking about. Oh, and I would add also that Medicaid has provided flexibility.
We've except Crosswaves.
Okay. Does provide the flexibility that if something unforeseen happens, like the drop of a problems with your transportation, then they switch you over to audio only and pay at parity.
Okay, thank you. Okay, can we blow that up a little bit?
That's not the, I remember one that was much more austere. It was just black and white. But I don't know if this is, that had percentages below. Do you remember? The one that you're having to blow up?
I think it's the one that had the dollar figures.
Yeah.
Okay.
There, that one.
And again, this is Sebastian Argomento from the Department of Financial Regulation. This chart doesn't have dollar figures. It has claims lines.
So I was looking at the percent. And they looked a little bit more similar except for Blue Cross Blue Shield.
Yeah, honestly, I'm a little curious myself because it has us paying, 1.8 million to 2 million in those 2 years, and then only 1.7 in 2022 and going up to 0.4. So I'm a little
I
curious.
think those are claims numbers.
Oh, those are the number of
Number of
claims,
claims,
not the
yes.
dollar. So it's probably a function of the total number of claims, but I'm not
Yeah.
really sure because I can't see what the percentage is of.
Yeah.
And again, these the charts that we referenced and the charts from the VPQHC slide deck should all be on the legislature's website from our previous testimony in the House.
Right, but do you stand by these figures? Like, do you see anything that sticks out to you if they all have a similar percent of audio only except for Blue Cross Blue Shield?
What stands out to me in these figures is that looking at scrolling down to look at Blue Cross Blue Shield, Cigna, Medicaid, Medicare, and MVP, and looking at audio only claims, the percent of audio only claims for 2022 is that Medicaid has the highest utilization of audio only services, with all of the commercial insurers being fairly comparable with each other.
Medicare probably has the people that would have the most trouble with transportation, no car. No life.
I'm looking at the bill page, and I don't know if Zane can help with this, but we got through the House with no fiscal note, and I'm guessing I know why, but I'm curious if anybody has quantified what the costs will be, if any, to the state if we go from the 75% to.
That would be Medicaid, if we could ask Nolan to do that.
Seems like
If I may, Joseph Barnard with the Vermont Medical Society, this bill only addresses commercial reimbursement and does not address Medicaid.
So Medicaid is a standing policy
Medicaid currently reimburses at parity for audio only, at least through the end of this commercial year they've committed to, and we've been meeting regularly with them to kind of get updated on where they are on that policy.
So if they change, it will come in probably to health and welfare, maybe you. So this, we are changing that policy, has no effect on us. Except on state employees insurance, so maybe we will ask for fiscal. Okay. Any questions, Mary Kate? Thank you.
Thank you.
Okay, committee. I'm still waiting for H Bill, so we can drag this out all week. But, we can, no, we don't need a fiscal note if we are changing Medicaid. So what are you thinking? I could put this on for a vote tomorrow?
Yeah.
But no, we will get a fiscal note from Nolan on the impact on state employees' insurance. Okay, so I'll get that. And we'll see where that comes in, and then anybody want to hear from anyone else? How are we doing? Yes, no, maybe? I'm sensing it's kind of a yes, but
Sarah looked like do you mind if I talk to a couple things? Because I think I can answer a few questions that you had. Sarah Teach out with Blue Cross and Blue Shield of Vermont. You asked about those kind of triage phone calls that people were making, especially to their providers during COVID, like, should I come in? Am I sick? You know, those things. So during the COVID emergency period, DFR had a bulletin and we all agreed to pay for those calls. It was at a much lower rate. So for about 2 years, health insurers were paying for those triage calls. I don't believe paying for them anymore. So really what this bill is focused on is calls that are supposed to be equivalent to a visit with your provider. So just to clarifying that, for E&M codes, which is one of the standard CPT codes, it stands for evaluation and management. It's one of the ones that are often billed when you go in for a visit. They are supposed to include some follow-up in the price of that visit. So when you go in to see your doctor for your regular checkup, follow-ups with some labs, maybe a phone call back are supposed to be included in that total price. So, you know, we do hear from people that doctors don't get, you know, paid for every single phone call they're making. And I do know that they are making a number of calls, but there's supposed to be some accounting for that in that E&M code. And then the last thing I would say about the parity requiring the same as an in-person visit is that it's different for every provider. So we all know that a primary care provider who works for a hospital, for example, is paid differently than a independent primary care, or a physical therapist working in one of our hospitals versus an independent physical therapist. So while you're all talking about parity and equal pay, this isn't equal pay. This is a different price being paid for an in-person visit, depending on the location of the provider, and you're going to perpetuate that for phone calls as well. And I guess I had one other thought is that the underlying statute already, well, maybe 2 thoughts. The underlying statute already requires health insurers to cover audio only services. So this isn't about audio only services not being paid for going away. That's already there. And
It's just at parity.
it's just.
Okay, I was like, otherwise, why did
No,
it be full parity?
This is-
Okay.
And you know, I have heard the arguments that providers are not providing audio only services because they're not being paid at parity. That's not what we're seeing. We have equal or more in-state providers who are providing audio only. When we look at unique providers and unique members getting audio only services, we have more unique providers and fewer of them are out of state providing services. I think that's because of the laws around being licensed and providing services into Vermont from out of state. But we aren't seeing fewer providers offering service, although I'm not saying that anecdotally there could be providers who aren't doing so because of the pay differential. So that's just not what we're seeing. We are seeing fewer people choose audio only visits. So there are fewer people who say, I want just an audio only visit versus either audio visual or an in-person. But we do, and I think I wrote it in the memo that I sent to you, if a call is set up to be audio visual, they start the call, but you can't hear, it's not working, you know, all that stuff. We do still reimburse at the in-person rate when when technology doesn't work, so. I think those were the few points I wanted to clarify.
Okay, any questions? Okay, committee, I sense we need a break. This is our last witness. So why don't you take about a 10-minute break and come back and we can talk about this bill for a minute unless,
Is that the last one?
that is the last,
Well, we
I
can
have
right
no
now.
bill. I'm trying to, set up some property tax discussions in the school, funding system discussions. That's really coming into my home. We have the, acting secretary, or
Oh,
has she been demoted back to her rich job yet? I would like to
not
get
yet.
I would like to get the new Secretary of Education in sometime,
Yeah,
but I'm not sure she's even,
she
Yeah,
starts till
yeah.
April 15th.
then she's probably not here physically, so. And we won't have some of the numbers, on adequacy payments until March 30th, I told them to be done
Yeah,
by Larry Pincus, so. We're just gonna muck around and see what we can figure out.
well, while we're looking,
Yeah,
so I mean, I know I've been thinking about some others have been. We have like the alligator mouth.
yes,
That's growing,
Yeah.
because we added new costs to.
costs are going up
education
and then things.
And we didn't add any new sources of revenue. I think, I just wanna make sure I'm still operating under the assumption that we're trying to look at ways we can close the gap for needed revenues to relieve pressure on the homestead property tax
I think there is a difference of opinion about that.
in this chamber. Is my
In
concern right now.
both chambers, I've
Okay,
heard that the amount of money necessary, $200 million. is
right.
Something we can't do, so I think we're looking at alternative funding, but we can look at everything.
Well, my mental kind of goal is $120 million. And I could be wrong, but to me, that comes from about $80 million of new cost pressure from the weighting and 40 million from
It
the
didn't
universal
make
school.
any difference this year.
No difference at all.
It was zeroed out. You lost 10%, you've got 10 cents off on your tax rate. So this is all with next year waiting, we'll have.
We'll have another impact.
We'll have another
Okay.
impact. And
But
that will be on top of this year's. I don't think they can cut it down. So it's anywhere near 10%.
Right.
So
You don't think we can find sales tax revenues that would make a significant impact at all? Do you have a figure in mind for what would make an impact?
I have been told to get it to 10% would be $120 million.
Oh, maybe that's what that figured.
But that's still, and 10%, that's an increase for the base.
Yeah.
And it will keep going up, and I think at some point, we're gonna have to admit that I've asked them to crunch the numbers, I haven't gotten them back, so I'll have to remind them, like, they haven't been busy enough.
Right,
But when I was selling real estate, the only places that didn't get kind of paid when they looked at the property taxes were New Hampshire and California. I'm afraid if this tax rate goes through, we may be equal or above New Hampshire, which.
I don't think we've seen everything in the house yet, have we?
I have been told that there are at least 3 or 4 tax bills headed my way.
I think we can take the rest of this week and hear from those agencies that have too many people and whose funds are too great. So we can adjust them down.
We can adjust them.
So we're gonna do appropriations.
No, the appropriations is a little concerned because the House tax bills raise the tax for a specific thing, which bypasses the appropriations committee. So the
a
appropriations
lot of
committee is
committees.
not, unless we want to do the same thing. But there is no question about the
Right.
propriety of doing that.
Right, well, we don't, I don't want to be looking at taxes that go to the education fund.
That would, one thing we've got is the cloud tax.
That's the one thing they're sending us that we know of.
No, they're not sending. We would have to do it
All the things, that's, yeah.
with all the things we have, we could look at that. But I think they have reached, they are not raising money for education right now.
None.
No.
That's new information to me, so I appreciate this conversation. I was under the impression the yield bill, which we were gonna get later than usual, they were gonna put the cloud tax, and I thought they were talking about a 10% short-term rental fee, and they were looking at.
Those
the yield bill.
taxes are coming.
I think the short-term rental fee is dead because it was a doubling
It-
of the rental rate, which
Yeah.
is 18%.
It was, no, the proposal as of Friday that was coming, if it gets out of the House, is an additional 10% on the rooms and meals tax. So everybody pays 9% rooms and meals. We will arbitrarily raise short-term rentals to a 19%. I have concerns about the legality of that.
I'm very confident in the legality of that.
Yeah, I mean, targeting taxes to one group is
Yeah,
something I'm not comfortable with.
and even just our definition being strong enough
Yeah.
to withstand that.
Yeah. Second homes, the tax department says they will be able to tell us who they are by next year.
Yeah.
Something about,
Well, so with that, you might want to get the treasurer on the record because he thinks he could find some money that we could use in the short term if we think there's another revenue source to meet next year. But if we need the revenue next year too, without paying something back from this year, that might be a moot point.
yeah, and the other question is, are we just every year raising money and propping up an ed system?
Well, that was the alligator mouth.
Yeah, it's not vital, plus there are vital functions of government we need to do, and right now we're
Right.
trying to find quite a few $1 million to keep the judiciary functioning.
Yes.
That is a constitutional right. So there's a lot of things going on.
So maybe you're not at liberty to say, but mentally, I was still thinking about 25 million that we need to find for the general fund, or has that number changed?
I think they need a lot more. No, they have not asked me to raise money. They
Okay,
asked us when we were doing the streaming tax, not to dedicate it to a specific fund, because that puts that, they get paid first before all the other government programs get paid. Yes.
I really appreciate you raising this, Senator Hinsdale. One other thing that just, it's important to say that we put on universal meals to the ed fund last year, and we didn't fund it. And we're feeling that more this year because we've hit that fiscal clip, and I'm gonna go on the record again and get some emails, but I really feel that we should look at sugary
Would
sweet
you like to
beverage
prepare
tax.
my pile of cards?
So if you're looking for some testimony, I'd
was
love
that
to.
from a past year, or was this year,
This is the when we put it in.
when we put it
The
in,
lobbying, what, I still want to know where all the money came from for that lobbying.
the beverage
Don't have-
association?
No,
I think it aligns some of our health or policy
Right.
objectives with our tax
Right.
policy.
And like everyone drinks seltzer now, I feel like the world has changed, but.
and that's what I've been
We
told,
last
is that
for-
sugary drinks are a declining revenue source.
Thank goodness.
I like the idea when somebody buys a Coke, they are funding
What are you
kids'
gonna
healthy
do with that new
schools.
stuff called pop that has minute amounts of sugar?
So that's where I think it's a worthwhile conversation.
It's called pop.
We will have Jim Harrison in to do his.
A great opportunity to manage our containers.
Okay, send them.
I think we've got a situation here
We do.
that we don't have the option of not addressing. I mean, it's,
Right.
now there was talk in the House about something sort of like in case you just mentioned that the alligator. The kind of the smelling.
Well, the picture is on the wall over in appropriations.
Oh, right now?
Yeah.
Yeah, the
Okay.
alligator.
I mean, it worked once. They, and it's, I, in my glib moments, I call it a Robin Hood tax. But it's, the idea is that they're a surtax on the high margins.
There is an income tax increase coming on the high end.
Okay, I mean, that's something we need to work.
It was time limited, as I recall.
Yeah, when it was the surcharge, that somehow meant time limited. The surcharge over there has meant a new tax bracket, which I don't think was.
I-
Well, maybe we don't call it a
One
surcharge.
year,
Right.
5 years, luckily,
Yeah.
clean it up.
The other thing is that, you mentioned a sugar,
Sugary sweetened beverage,
yeah.
which was in the childcare report last year, so it came
Yes.
out.
But do you know that diet drinks are much worse for you than sugar beverages?
I'm happy to include diet. I think we could stop that debate and include diet.
And the other thing is not a tax, but where the money goes, where money comes from. There's a lot on the school budgets that maybe should be moved off the school budgets altogether, including stuff that probably everybody in this committee is looking for, stuff I know I voted for. But my sense is, well, it's sort of a dirty trick on the school budget, but we really do want those meals and they'll find a way. And
What
no,
we're
maybe
going to
they
put
can't.
Holocaust education.
Yeah,
All right, that's,
Well,
so
that
what have
again
we
goes-
put on schools? We've done school lunch. Okay, what else?
Sounds like waiting impact will come.
Pardon?
The waiting
So
impact
so
will
I
come.
will come
Waiting,
The impact of Act 127.
straight 2 days off the week. But again, this is a great opportunity, and I keep repeating it, of going back at some point, and this will be a year-long project. To do what the Blue Ribbon Tax Commission was scheduled to do in 2010-11. We need to straighten out the mess of taxation we have. Because we keep fooling with it, we change it every year, it's incomprehensible in terms of education funding at this point, and now we're adding to the rest of it. And we don't know how well it deals with issues such as fairness and equity and those kinds of things, because we're constantly fooling with it and it changes the base.
Senator Brock, are you referring to the one of the Blue Ribbon studies, when you say 2010?
The original, which was designed to look at all three taxes at once, if you recall, and we wound up looking at only two of them. We didn't get to the property tax, and so the next year, when there was a change in administration, all they looked at was the fairness, quote unquote, whether it was achieving what it was designed to achieve and the way that it was doing it with the property tax, never looked back at the first two taxes, recognizing that what was said in the beginning was unless you do all the taxes at once, you're going to establish something, you're going to fool with one of them, and then it's going to throw the balance off, and you're never going to get it right. And that's what we've been doing in the past 10 years, 14 years.
The original version talked about the 2011 report, 2010.
Right.
That you would expand taxation to services, but lower the sales tax.
Yeah, that's one of the things I proposed. There was a,
And I've heard since then though that whatever, well, we've created a situation where you could expand into services, but no longer was there a capacity to reduce the sales tax rate. So there's there's a new state, but no carrot anymore.
but there are a whole bunch of changes, which, as I said, you can't go back to what was done then,
Yeah.
because everything, including the way we calculate income taxes, has changed.
Sure.
And, you know, the changes we made in the property tax alone have further compounded the problem.
and, yeah, the property tax doesn't get, that first committee was to look at our competitiveness. And the focus really was on the income tax rates, because we always came out at the highest marginal. And there were all kinds, no exceptions, no flat exemption.
And the whole idea was it was gonna change to adjusted gross income.
Yeah.
And adjusted gross income would cause the tax rate, highest tax rate to go down 2 points. Well, we, fast forward 8 years and we got to adjusted gross income, the tax rate as high as it was before, because we didn't do any of these other things.
So what did the last Blue Ribbon Tax Commission recommend? Because they looked at education.
They said to go to an income base.
And then that,
But I think a lot of folks have real concerns about the quality of that last report.
It wasn't,
It was
You said-
just, it was not up to the first one.
okay. I will ask Nolan for a fiscal note on the impact on healthcare. I hope we got some HBOs. They told me they came out Friday before crossover, so, our crossover. So, as soon as we get them, we'll take them up. But right now, this is the only one I have.
can I ask, is the governor's office going to propose any cost containment measures that you're aware of?
I think they're waiting to see the dust settle for what we do.
That would be standard
There
procedure.
will be, I mean, I think there'll be a lot of comment about what we should do. I think we'll hear that in the next few days,
The next few days we'll hear,
what we haven't done. Like we haven't passed a housing bill. Which we said
Right.
is the greatest, most important thing we've got to do in this session. We haven't done it, neither chamber's done it.
I thought they.
Got anything else?
had housing.
with,
I thought,
I don't know if I would characterize it as a housing bill.
It's an Act 50 bill.
Well, there's the Act 250 bill and then there's 829, which
okay,
came together quite quickly, in my view.
I don't think we
I don't
put
know.
that on miscellaneous tax. We might,
On the housing
that's
front,
my only
all
Christmas
roads do
tree.
well, I think.
Okay. All right,
I welcome that discussion on other ways for cost containment, including bringing back in a phased manner the excess spending limitations that was in place that was suspended for 5 years. I'll work on that as drafting something for the yield bill. I'd love to explore more of now that we have new long-term weighted average pupils, some sort of expectation that they exceed spending per pupil by more than 5% with this new weighting world, some sort of again, excess
Yeah.
spending, either cap or penalty, but penalties worked and I think it's worth bringing
Yeah.
it back.
I think they will be going back in.
And then the last thing, if you're looking for people to talk to, I don't want to drop the ball. And I don't know if this is being done in your committee and so I'm looking for an update is, I'd love to hear from the tax commission that how to move forward to disambiguate second homes in our non-homestead taxes so that we can have a higher rate, because that's aligning our tax
Let's
policy
ask
with
the
our
tax
housing
commissioners
objectives.
come over for that specific question.
Well, Emma, he's supposed to be coming over, I would think, for the whole housing bill anyway. Has he not?
For what housing?
Did you want to start talking about the property transfer tax and the other?
No, because the housing bill is sitting,
Oh, well, I think everybody had dispensation to look at the sections that are not Act 250 or zoning.
well, we look at them. The tax commissioner did not come.
Maybe he could come, because
Okay.
that's the first step. He, from my recollection, agreed it was possible to do second homes for the property transfer tax because it's a discrete number and they can sort of have a back and forth. And I think that would give them a lot of information about how to implement a full property tax second home rate change.
And there isn't also a rework of the property transfer tax coming, I have been told.
What I'd like,
I don't even
I
think I want to touch.
I just want to make it more
I
careful.
told them that we had an alternative proposal.
Yeah.
Taxes incent behavior, and I like the idea of taxing second homes because that will possibly incent more people to maybe become full-time residents in Vermont and maybe pay our income tax and also
Yes.
contribute more to our economy. Or it will motivate them to put people under those roofs. So I just don't want it to be dropped, and I don't know if this is the finance committee or.
But what we don't know is how many homeowners, and there are a lot of them, rent their house out while they're not living in it. Many senators are staying in homes that people are not living in.
If they had a landlord certificate, they,
No.
our bill is structured so that if you could produce a landlord certificate or a homestead declaration, you're not subject to a tax.
Read that by him, I think it's gonna take off. I think anything that is not registered as either a rental property or a homestead or business could be taxed, but
Mhm.
they say no. I don't know if that's foot dragging.
Well, I say we draft something to give them a year to figure that, like, we just let the intention be known that next year it's happening.
Well, no, we
Because-
have to find something to stick.
I think
The
we
House
have
will probably send
legal
us
options.
yeah, to stick it on. There is a yield bill coming
You could also put it on housing.
Well, they can't do a yield until they know what the school budgets are. So we may not get that until the last week.
When, so is the last vote April 16th or?
Well, some
can
of
they go
them,
for
Barry's already
May?
moved theirs to May,
Okay, so we,
but we need at least to get the March ones.
Yeah.
In.
The former state senator I greatly respect has said it's all talk until you put something down in writing. And so I just would, I'm happy to do this on my own, but I'm wondering what you suggest to make more productive discussions of getting language to add to bills.
I think as a committee, we need to get the information we need. And then you can start drawing up bills. And people can take responsibility for one or the other. So,
so Bolio.
we will ask the commissioner in.
Use the sugar sweetened beverage with. We have to ask you.
I don't think I've ever seen language for that. It was just in that
Yeah.
childcare bill, and it seems to make sense to me to fund universal meals.
Yeah.
And tax sugar and beverages.
The last time we looked at the language, I think it was 20.
Okay.
Yeah,
So we need to get
hopefully
Tom's
the bill, there's, and then there's hopefully the bills that you could check back for 3, 4, 5, 6 years ago.
So should we ask JFO? I know Sarah was there for those.
Probably, you know, we could start like 90%.
Yeah,
I don't want to do just sugary sweet, I want to do diet. Diet does more harm than
so
sugar.
great. What do we call that? That's all.
Artificial sweet.
Soft drink tax.
Carbonated sweetened beverage.
Doesn't have to be carbon.
No, then you pick up
Oh.
seltzer. Do you want to pick up seltzer?
No, just the
Where's
sweetened
Harris?
and carbonated. I thought we were going for sweetening.
And our yogurt covered raisins,
Yeah, oh yeah, I know.
or is candy
There's a
covered
trio.
raisins? What is a sweetened?
Are we doing
One
junk food
minute.
checks
Yeah.
or? Oh, okay.
Our critics, our critics have said, all we want to do is raise taxes. What I want to do is shift off of
The education.
the school tax onto other taxes.
Agreed.
Okay, and if that's what we're gonna, because the tax is causing agony now, it's the school tax.
That is the only
So-
tax they've let me raise until the, the,
So if we keep in mind that that's what we're
Yeah.
thinking about,
yeah.
then I feel a
believe-
little more cavalier about raising taxes
And
than I have.
I
otherwise.
wanna make sure I'm correct. I was on a radio program this morning where they said the governor said the same thing. That the governor is saying he will consider taxes being raised that offset the homestead education coverage.
Yeah. And I would, again, I don't know about the rest of the committee. If I'm alone on this, so I'll just shut up, I
No,
guess.
you're not.
But I'm on the wealth tax,
Oh, the wealth,
which is
there
not
is an
punishing
increase.
people for being
There
rich.
is an increase, there is an income tax increase coming our way.
Okay,
I don't think it's going to be collecting money on unearned dividends or unclaimed dividends. I believe it is going to be either a fifth or raise in the top rate.
and then I think what we need to do is identify how those revenues are going to be applied to the school budgets.
Oh,
Okay,
Yeah, we'll have to
how they actually become
well, if we put
property
it
tax.
in, we can,
Like, make sure they get printed.
But they,
yeah, we control the ed fund. So we could say it would be used to offset the cost of universal school meals. I don't think that would be going around to folks because they don't appropriate it. It's not general fund. Same good point.
It seems like one of our challenges, I don't know if this is quite how to address it, but I'll just start with. Even though 71% or something like that of Vermonters pay based on income, not property tax. We still end up with a lot of people seeing a property tax bill and thinking that's what they owe, and we don't. I'm not looking for credit, but I'll say it this way, we don't seem to get credit for having found a method to reduce their tax obligation by virtue of having income sensitivity. So I'm just thinking that there's some math we need to do to complete the system. I'm also just trying to think of how we deal with the perception that People don't acknowledge the,
But that cliff is also quite precipitous. I mean, like you go from getting income sensitivity to paying
No,
up really.
we explained, we explained.
We've slowly.
income, our income sensitivity.
Income, you pay based on income. I've a
Foundation
lot
plan
of
is
doors
sensitive.
knocking on to finally understand when we did that. Fine, my tax bill's going up $100. The guy next door is more income sensitized, his is going up 10. But on his fixed retired income, he can't afford that 10. It's coming out of their groceries. And so it keeps going up. The 25% of people in the state of retirement age and not now soon to be on fixed incomes. Their income isn't going up anywhere near the rate. Social Security hasn't raised it as much as property taxes are going up. So I'm losing.
So good point. I'm just trying to be aware of,
Yeah.
no matter how hard we try, sometimes, and even if we actually do change the nature of what some is obligated for. Sometimes people persist on feeling like we didn't do something helpful.
The only tax that people are really concerned about, other than the fees and the DMV, is the property tax. That's the only one that's going up. And we don't raise inflation, but that's the one that's really at risk. And that's when we have to say, what's a reasonable property tax to be?
And it still goes up if your income sensitized and if your property value is going up, it still goes up.
And there's a point where we only cover, what, $200,000 worth of house?
But if you're paying based on income, you decouple from your property.
You're not decoupled.
Property tax
You just get a
rates
break.
and the rate of taxation on income go up at the
You
same
just
Yes,
get a
percentage.
break.
Yes, so. And you get tax, based on your school tax. If your school tax spends more than the average, then.
Just as have a senator with a constituency with 3 out of 4 school districts that have had tax rates go up because of the pupil rate changes. I just want to, they are looking at failed budgets that they are in 2 weeks, 3 weeks from now, going back to the voters. And with meetings yesterday, they are looking for Montpelier to say that they heard the voters and rejecting these budgets, and they're wondering, and it would help them make the case to their voters to support this new budget if there's some communication or some idea, or not, if it's not the case, if we are going to find additional revenues to buy up the yield, buying down the gap, that widening gap, which I know won't eliminate the entire 15%. I'm not proposing that, but anything will help to get a lower tax rate with a
But
better
next
yield.
year, they're going up another 8% or another 5%.
But then we also dedicated other types of revenue to it than the property tax. So we've at least
Right now,
closed the mouth.
the sales tax is there.
Right.
That's what it
But
has.
if we don't add new types of sales tax, we continue to only put it on the education property tax.
Right, but the schools have received $20 million a year more since COVID than they would have under the old general fund transfer rules with an inflation inflator every year. The schools have gotten a lot of money. That money's gone away. People aren't out spending their federal gifts.
I will say, people equally asked at the constituent meeting I went to, that wasn't at the school board, that we look at cost containment. I think it's a both and I think the governor's signal might have been a big one. He said he would consider new taxes that offset education property tax if we also do cost containment. What I like is some proposals from the administration on cost containment. I think
We can have the superintendents in to talk about cost containment.
Right.
Okay.
Well, I mean long-term ones. I'm not talking about them cutting right now, but things that overall just sort of help them know the sandbox that they're playing in. But the governor should be participating in that conversation.
He never has, and he will. He would just yell at us. Okay.
Well, I was gonna say, Senator, is there like, if you wanna make a vote on how to change something, press conference. If it's a serious proposal, I think we show up with something black and white between the 4 corners of the page, if that's what we want.
Okay,
That's the money for.
For every, inside and outside.
this week,
Well, are we going offline?
are we finished? I think we're finished. Okay.